At Myron Construction, our passionate team members rally together every day to create meaningful connections and capture what truly matters. Within our offices and out on our project sites, Myron's strong culture and core values permeate everything we do and guide our approach to serving our clients, our communities, and each other. Together, we're building excellence.
Good morning, everyone, and welcome to the Iowa Ideas Conference and this morning's session, Medicaid and Hospitals. I'm Tom Barton, the Gazette's Deputy Des Moines Bureau Chief. I cover Iowa politics, including the Iowa legislature and campaigns. I'll be serving as your moderator, helping to guide today's discussion and conversation as part of Iowa Ideas, which seeks to explore the issues, address challenges, and share the big ideas that will shape the future of Iowa. I'd like to recognize our presenting sponsor, ITC Midwest, which helped make this virtual conference possible. And I also thank you to Myron Construction for being a content block sponsor for this panel discussion and for this conference. A reminder that audience members can submit questions to our panelists through the Q&A function. The session is also being recorded and closed captioning access should be available. And joining me are Chris Mitchell, President and CEO of the Iowa Hospital Association. Welcome, Chris.
Good morning. Welcome.
Thank you. We also have Shelley Cleverly, Chief Financial Officer with Washington County Hospital and Clinics. Welcome, Shelley.
Thanks, Tom.
Yeah. And we have Bill Grimm, CEO of Community Health Centers of Southeastern Iowa. Welcome, Bill.
Thank you, Tom.
Yeah, again, thank you all for being here. Appreciate you lending your expertise to this discussion. So I'll just kind of set the stage. Iowa hospitals are in a period of uncertainty as changes to Medicaid enacted as part of the sweeping tax and spending bill take effect. Is a fund allocating billions to some rural hospital, or excuse me, is a fund allocating billions to some rural hospitals to help cover their losses, easing concerns. What does this mean for the state's rural providers? We'll unpack the changes in Medicaid and what it means for Iowa's hospitals and providers and how those changes might impact you. So as I mentioned, Iowa's hospitals are navigating a period of significant change and uncertainty. As many of you know, recent federal legislation has included major adjustments to Medicaid. Like I said, on one hand, there is a new fund, federal fund designed to offset rural hospital losses, again, with billions of dollars allocated nationally to help stabilize struggling providers. On the other hand, hospitals and clinics are still trying to understand how these new rules will affect daily operations, patient access, and long-term financial sustainability. Roughly 700,000 Iowans depend on Medicaid for their healthcare coverage, and many of the state's rural providers are lifelines in their communities. So again, the question is whether the funding will be enough to address pressures hospitals are facing, from workforce shortages and rising costs to changes in reimbursement and eligibility. Like I said, that's what we'll be unpacking today with our panel. Chris, I'm going to kind of start this conversation off with you. I guess, how would you describe the current level of uncertainty hospitals are facing with these upcoming Medicaid changes?
Yeah, absolutely. Thanks, Tom. Hospitals are entering a period of deep uncertainty following the passage of the One Beautiful Bill Act, or OBA, or HR1. It's been many names to it, but effectively, the potential loss of coverage for thousands of Iowans, combined with the financial strain from changes to reducing payments to Medicaid, puts pressure on the very communities, as you mentioned, our lifelines and our communities rely on. and particularly for our rural and safety net hospitals, the stakes are especially high. But despite all of this disruption, I will tell you, as I talk to hospital leaders from across the state, their mission remains clear: to care for their community, to adapt to the changes, and continue to advocate on behalf of hospitals and the patients they serve. And they are all stepping up, not just really to manage the risk, but more importantly, to protect access, strengthen partnerships, which we'll hear a little bit about today from some of our other partners in the community, and to ensure that no patient is left behind and they can get the care where they need it and when they need it.
Yeah. So from your perspective, I guess, what are the most significant provisions in the new tax and spending bill that directly impact hospitals in this state?
Yeah, I think you touched on the one piece, and I look forward to talking more about the $50 billion Rural Health Transformation Fund. But I think in addition to that, we know that given the passage of this, it proposes about $1 trillion in cuts to healthcare across the country. And in Iowa, what I'd say is the most significant cut to the Medicaid program is some of the limitations they put on our directed payment program, which essentially started 3 years ago and really was the first time in 10 years that we've had any sort of investment in the Medicaid program. So to see that potentially cut in half when this bill is in full effect is certainly the most problematic. I think on the flip side of that, there is some time here. They put a delay into the bill, so the cuts don't come into effect really in Iowa until July 1, 2028. So I know that hospital leaders and policymakers are using that time to continue to figure out how we're going to mitigate these cuts and ensure that patients continue to enjoy the access to care that they have now.
Yeah. I don't want to get too into the weeds, but for those who may be watching and listening who aren't familiar, can you kind of describe just briefly those directed payments that you mentioned, kind of what they are and how hospitals use those?
Yeah, sure. So Iowa's directed payment program essentially provides utilization and delivery. The payment program provides supplemental payments to hospitals to help advance the state's healthcare priorities. This is obviously a partner with the state as well as the federal government. So CMS essentially requires that these payments that get sent out to hospitals quarterly are tied to utilization and delivery of service, and are measured on the use of these by taking a look at certain quality metrics that align with the state's quality strategy. So these funds were allotted to Iowa to essentially boost Medicaid payments, work to increase quality, and preserve access to care. And if you then think about some of the cuts coming down the road, the program will essentially be cut in half when this bill is fully implemented, which will have significant impact on hospitals who were just beginning to climb their way out of some of the financial strains that were brought on by the pandemic a few years ago.
All right. Bill, I was wondering if you can kind of add the community health center perspective. Are you experiencing similar uncertainty, or do they face unique challenges within Medicaid reimbursement and patient mix?
We are experiencing the same challenge, and we're relying on the Iowa PCA, who's working, I believe, with the Iowa Hospital Association on what this $50 billion grant will do for us. So we don't know yet what that means for us. But as a community health center and someone who's been in hospital administration for almost 20 years, we're actually seeing not just cuts from Medicaid that we have to plan for, but 340B program getting, changed drastically that, helps us safety net providers provide services and drugs at a discounted rate. So, that's going to impact us. Now, I'm not personally against having work requirements for someone that can work being on Medicaid. But the problem with work requirements that have been established from other states that did it is it's very hard to get for people that need these services to actually, send the information they need in. And right now, the Iowa doesn't even have a program in place to actually capture that data. So, luckily, Iowa had passed a thing to put these in place and at the, I believe, end of April. So those have been, like, I believe, tied back to the federal bill. So, we have more time to work with, Iowa and how do we get the system in place? What we don't know now, are we able to help people with community health workers apply for coverage? So right now, as a safety net providers, as federally qualified health center, 52% of our revenue comes from Medicaid. So yeah, if there's a $1 trillion cut across the country over 10 years, that's going to impact us. And the models we've looked at are about a 10% cut in revenue to us. So that means staffing changes or potentially closing services or closing locations. So
Wow. I guess, have you started to kind of make those planning decisions as to what staffing cuts you would make or what services you would scale back or cut?
we have not fully made the decisions, but I will say I've been here about a year. I moved from Ohio to Iowa, and in the last year, we've actually cut our FTE count from almost 197 to we'll be at 157 people in preparation for these changes. So, that's 40 Iowans that aren't working because we have to be ready for these things. But we still have the same amount of patients that need care. So it's just putting more on fewer people to provide that care. And then, we haven't talked yet about the fact that wages, we have to match the hospital wages, so right now, we have to give people raises or they're leaving. So, and there's just not the funding to do it. So basically, anytime someone resigns from a position here, we're making a hard decision. Is this absolutely necessary to replace this position, or how can we leverage technology, AI, to replace some of these positions?
Yeah. So those 40 positions that you mentioned, I guess, how much of that is due to attrition?
We have not done any layoff at all, so it was all attrition. So
Okay.
I will say we were a little overstaffed here when I came on board about a year ago. So I think we've right-sized, but we can't really go under where we're at right now without really impacting patient care.
Yeah. All right. So we've mentioned this earlier. I guess let's delve into it. The bill includes a $50 billion rural health transformation fund. And Chris, you can correct me here if I'm wrong. I believe half is allocated evenly to states and then half through federal grants. Is this a meaningful solution, or is this more of a temporary patch?
Yeah, I mean, can I answer? It's neither really, and I'm happy to clarify that a little bit more.
Yeah,
I
please
think,
do.
yeah, I think first and foremost, if you talk about the intent or how this was marketed, I think folks generally believe that, hey, rural hospitals are going to be cut and they're important in the communities they're in. As a result of this, we are going to create this $50 billion fund in order to help rural hospitals. But none of these funding can be used to replace the cuts that were put into effect. The name Rural Health Transformation Fund, if you've listened to the Secretary Kennedy, it's really to do two things from their perspective: to transform how rural healthcare is delivered and also to continue to push forward the Make America Healthy Again agenda. And that to me is distinctly different than mitigating the cuts that we're facing. I think our members are very much engaged in the discussion and trying to shape how these funds can be used and benefit rural hospitals. But I will tell you, they are not believing that this funding will mitigate the cuts that are coming down the pike here over time. And if you look at the total amount of cuts as being almost $1 trillion, and you talk about this fund only being $50 billion and lasting for 5 years, that's still well over $900 billion in cuts that that the healthcare community is going to have to face.
Right. Do you know at this point what the cuts would amount to, or what that looked like in Iowa, and what the state would stand to receive or gain from this rural health fund?
Yeah, so the application process is ongoing right now. So we are working closely with the state. I believe that the applications are due November 15th, and the awards will be announced before the end of the year. I think we feel confident from where we sit that Iowa will get the $100 million that's allocated evenly amongst all states. And we do believe we will receive an additional amount above that, given some of the criteria based on the strength of our application. So, you know, more than $100 million is likely. I can't tell you much more than that. As it relates to the cuts to Iowa, from the directed payment program alone that we talked about earlier, we're talking about $750 million worth of cuts to Iowa. So again, that doesn't cover the shortfall whatsoever, and the funds again can't be used to pay for the delivery of healthcare services.
Yeah. Shelley, you raised this question in our pre-panel discussion. In that question, how do hospitals actually use these funds for workforce retention or technology like telemedicine and AI? I guess, what opportunities do you see? What pitfalls?
Yeah, the funds really should be prioritized to ensure that patient care remains intact and that care can still be delivered, albeit more efficiently and for less cost. The funds also probably, they should be used to increase efficiency and reduce overhead. So AI and investing in technology, that has the opportunity to do both of those things. Telemedicine can be really effective when it's appropriately paid for, when the providers are being compensated for the care, and when there's reliable service, where there's the capacity to provide reliable service. And that isn't always the case. The thing about telehealth that's great is it does allow patients to stay in their own communities to receive care at lower cost. So, there are some opportunities, but, I really like that Chris mentioned that the $50 billion really doesn't touch the cuts that we're going to receive. It's kind of a completely separate bucket of money. And we don't really know what that looks like. And, the state is putting in the application, doing what we're supposed to do so that we can get our fair share. But then as individual hospitals, we don't know what that next step will be for us to apply for those funds, if it will be competitive grant, or kind of how those funds will be allocated amongst the rural providers in the state.
Yeah. So a follow-up to that, I guess, have you provided any feedback or guidance to the state as it's developing its application as to what should be included in there, how the state should prioritize how these funds are used? And if you haven't, I guess, if it were you drafting this application, how would you go about that?
Yeah, our CEO has been involved in some talks with some legislatures to kind of talk about what we think is important, and really we talked a little bit about it already, kind of AI and the investment in technology. That is where things are going. That is kind of the future, not only of healthcare, but of everything. So we want to make sure that we use those funds to invest in those things, because as Bill mentioned, the workforce strain, the increasing efficiency, decreasing cost, all of that, AI and technology can help with that.
Yeah. So I'm sorry, Chris, did you want to jump in there?
Yeah, I just wanted to jump in on the providing feedback. I think in addition to what Shelley said, we've held a series of meetings, surveyed the membership, and we've heard from almost 100 hospitals within Iowa what the priorities are for the spending of the Rural Health Transformation Fund. And we've been able to share that with the state. So they've been a great partner thus far in trying to understand the needs of rural hospitals to best put this application together.
Yeah, and in general, what has been the feedback from those hospitals?
Yeah, I mean, I think Shelley really touched on the general consensus. To me, it really fits inside the access to care bucket, whether that's workforce related. What can we do to continue to recruit and retain the healthcare workers that we have? Is there a way to leverage technology to help really give our physicians more time at the bedside instead of filling out reports and forms? So just really trying to be creative and make sure access is continued to be available in rural health in rural areas.
Yeah. Bill, one thing I wanted to follow up on that you mentioned, and I'm kind of curious if you can elaborate, I guess, are there particular services, or I guess what services do you see, I guess, most at risk, even with this fund in place?
I think, our service location that's most at risk is one that's in Columbus City, which I know Shelley, the Washington Hospital, also has a clinic in that area. We have probably 35% self-pay there. It's in Louisa County, which is a very rural community. They have a big Tyson plant there, but with some things that we just don't know too is, can we use grant money to provide care for people that are in the country illegally? Because right now there are people in the country illegally that do come to community health centers and hospitals for care. And right now, we're, as a safety net provider, we have a sliding fee scale. So if someone comes without insurance and they're under 200% of federal poverty, they can see a provider for $30. So they're not left with a huge bill. But as more and more people fall off Medicaid, and we have more and more people paying $30. I mean, $30 if you have, 3 visits an hour, that doesn't even cover the provider salary, let alone the support staff, the registration staff, the billers. So, it's just a challenge. And like Chris has said, from hospital CEOs and health center CEOs, we're going to get through this. We're going to come out stronger, but we don't know what it's going to look like. And there's just uncertainty. And that's the biggest thing I think I want, is a certainty, like what funding is going to be here, what's going to be the next step, what are they going to take away next. And it really, for me, comes down to whether people believe healthcare is a right in this country or is a privilege. And unfortunately, I believe, in the US, healthcare is a privilege right now. Because if you have healthcare and you lose your job where you had that healthcare, yes, you can buy a plan, but if you just lost your job, you may not have money to buy a plan. And then we also have the next cliff coming, the ACA tax credits that, the reason the government is shut down whatever you believe there without getting political. We need to either extend those tax credits or no, because the pricing of those plans is coming out here for open enrollment. And if people don't know what tax credits are available, they're not going to buy plans. And then we're going to have that, falling on, health centers, and then, ERs, where patients lose their insurance, and ERs aren't meant for primary care, but that's going to happen. So, I mean, we just have so many things happening, and, we'll get through it, but we really want certainty. So.
Yeah. So as we've mentioned, beyond funding formulas, hospitals are also dealing with workforce shortages, tight budgets, rising demand. Chris, I think you had mentioned either during this discussion or during our pre-panel discussion that hospitals are already kind of trying to factor these looming cuts into long-term planning. Are they delaying expansions? Are they cutting service lines, or leaning toward, conversion to like rural emergency hospital models?
Yeah, I mean, what I would tell you is hospital leaders, I think all solutions, all are on the table. And the simple fact is, from a hospital financing standpoint, on about average, half of the revenue at hospitals is either related to Medicare, which is controlled by the federal government, or Medicaid, which is a state-federal partnership. And they determine how much hospitals will be paid. So over half of their revenue is sort of baked in, and there's not much they can do about that. So if you think about that, it doesn't really leave a lot of levers for hospitals to mitigate these cuts. And so really the first natural, and I'm sure Shelley would agree with me, it's like, well, do we have to offer certain levels of service lines? Does it make sense there? Or we have to lay off staff, like Bill has talked about. And none of those really do anything except threaten access to care in the community. And so if a hospital closes their labor and delivery services due to these Medicaid cuts, it's not just the Medicaid population who is impacted. It's every single Iowan in that community now does not have access to OB and delivery services in that community, and will have to travel someplace else.
So do you anticipate more closures in the future, in the near term?
What I would say is, yes, I would expect that some services will have to be reduced as a result of this. I mean, we've seen we went about 20 years in Iowa without a single hospital closing. And then I think over the past 4 years, 3 hospitals in Iowa have closed. So we know that there is a reduction of services in communities across Iowa. And I don't think the passage of this One Big Beautiful Bill Act does anything to mitigate that. It might actually speed some of those processes up.
Okay. Shelley, you mentioned workforce strain, competing with fast food wages for support staff, and then considering AI tools for back office tasks. I'm just wondering, can you kind of expand on how that plays out in a small rural hospital, and maybe how you guys are working to try and address those workforce strains?
Right. Yeah. So, we compete with retailers. We compete with fast food restaurants for a lot of the non-clinical jobs that we have. And it's a completely different kind of work too. When you work in healthcare, it can be heavy. It's a lot of responsibility. It's incredibly rewarding, but it's also heavy. So, we talked about it a little bit already, about leveraging AI. And so, if we can leverage AI, it means in some instances, there is a fewer need for people in healthcare, the healthcare workforce, than there is today in some areas. So that means expense reduction, and that means increased efficiency. But the pitfall of that is that, AI does have implications to the workforce in general. So, if you need fewer people in a certain area, can they be redeployed into a different area where maybe you have a need? So, there's always a everybody has a nursing shortage. It's hard to find nurses. Can people be retrained or trained up to move into a different role? But whatever happens with AI and workforce, I think it has to be studied and anticipated, so it's not a surprise to anybody.
Yeah. Bill, are community health centers kind of making similar adjustments or finding creative ways to stretch limited Medicaid dollars?
We are the same thing Shelley just talked about. We're looking at AI. We're looking at AI call center to answer our calls and schedule patients. That's something we're actively working on right now. Kiosks for registration, because just nothing bad, but when a registration person, you have to start paying them $20 an hour. That's a lot of money to attract them. And it's not, I'm not saying $20 an hour is a lot of money. It's just for when we have to have a lot of them. So, AI is going to transition. So instead of, 8 people sitting at windows, you may see 2 people that are helping the 8 kiosk users get logged in. And then, what Shelley talked about is transitioning those people and training them to room patients or be staff that can not do what AI can do, or have fewer people there so we can pay more for those back staff positions. We're looking at billing. How can we do coding, billing? We've already implemented ambient listening for all of our providers, so when they're in a room, they have Nabla listening to the call, and as soon as they walk out, that note is pretty much done. So we've been able to increase the number of visits a provider can see when they don't have to go and chart after the visit. They just have to put the orders in and sign off on the note. So that's been helpful. We've already implemented that, and so we're looking at AI. Unfortunately, AI is in its infancy, or infancy. Oh, I can't say that word. Sorry.
Infancy, yeah.
Yeah, infancy. And we're still looking at the solutions out there, but AI comes with a cost too. It's not cheap to buy different AI solutions and that kind of thing. So that's probably where some of that 50 billion will come in, is helping us put some AI solutions in place.
All right. So at the end of the day, it's not just about institutions, it's about patients and communities. I'm curious, what happens to patient costs, wait times, or health outcomes if hospitals are being forced to scale back? And I'll just kind of throw that out to the group. I don't know if anybody wants to start.
So Medicaid cuts will require all hospitals, all medical professionals to make choices about the services that they can provide. When there's less money in the system, there's less access and less choices for everybody. And that's just what will happen. We currently provide some services that aren't profitable, but they meet a community need. So we provide them. If these services aren't subsidized through something else, some other source in the future, then they will be at risk of being cut. Like Chris mentioned earlier, that's what's happened to OB in much of the state. So in order to sustain core services like primary care or emergency department, OB had to be cut so that funding could be focused to that. So I think this is going to be a big impact in all of those areas all across the country.
Yeah. Aside from OB, are there any other examples?
So we closed our OB in 2018. So that is a service that we at that point decided that we didn't have the number of births to sustain that service line. And we chose to kind of refocus on some of the primary care services that we provide. You know, I would assume that there will be, I mean, as Bill mentioned, potentially clinics that could close, you know, clinics that are maybe located in more rural areas.
Yeah, the other service line I think that is that I hear a lot about potentially is behavioral health services. Again, as Shelley mentioned, usually filling a community need, but outside of that, there are significant costs and liabilities associated with it, just like OB services. So that would be another one that I would lift up that could have potential to be cut from some rural facilities as these cuts continue to move forward. And really for hospitals, it's sort of a double whammy here, right? So we know that the Medicaid cuts will force hospitals to either reduce or try to maintain access to services. But then on the other side, we know that some folks who are eligible for healthcare today will not be eligible for healthcare once this bill is fully implemented. So those folks who are going to see their doctor every single year in their doctor's office or a community center or a clinic now wait till they get so sick that they show up to the emergency room where we have to treat them. Again, they do not have health insurance. So there will be a cost to that for hospitals as well. So really from our perspective, not only does that impact the hospitals, but you talk about wait times. Well, if people who shouldn't be in the ED are in the ED, and then Tom, you show up there with an emergency, then the response to you and the response to the care you need might be delayed as a result of that.
Gotcha. Just a reminder to our audience members, people who are watching and listening, if you have questions for our panelists, if there's a issue you know you're interested in, or again, if you have a question, put that in the chat, and we will get to as many as we can in our remaining time here. So let's kind of look toward the future. I guess, what would you like state lawmakers or Congress to do to provide stability? And maybe Shelley, I'll start this off with you.
So I think, you know, we would really like a conservative approach to the Medicaid restructuring, kind of the slow roll rather than all of it all at once, so that we have time to adjust to those changes. So anything that Congress could do from that perspective would be incredibly helpful.
Okay. Bill, what about for you?
I'd second that, just slowing down the changes and having consistency, and because we need to know what's happening so we can plan.
Chris?
Yeah, I certainly would echo that. If these cuts have to go forward, certainly allowing hospitals and community health centers and communities to brace for those with a longer tail. But really, I look at this 3-year period is really an opportunity for hospitals and communities to continue this conversation about what these cuts would do. And hopefully, when you look forward to 2028, when those cuts are supposed to start to come into effect, well, 2028 also happens to be an election year. And I can tell you, sitting here today, there will be 2 new members of Congress who did not vote on this, who will be elected inside the Iowa delegation. So I certainly would like to get them up to speed about the potential impacts those cuts would have to hospitals, and maybe there would be a change in heart or thinking about mitigating these cuts even further or delaying them out even longer as we try to sort out how to best move forward as a state and a country.
Yeah. So just following up on that, like you said, one thing on hospital side is time. You got 3 years before the cuts fully hit. I guess how else should policymakers, in your view, be using that time?
I think they need to be using this time to meet with hospital leaders, hospital trustees, hospital CEOs, hospital workers, community health centers, and really dig into what those cuts are going to mean, not only to that facility, but to the patients they serve, to the employees that work there. I think, Tom, when you and I talked, I made the point that every single person in this country is going to interface with a hospital in some way at some point in their life. And really to build a tax plan and a bill cutting facilities like that is troubling, at least from my perspective. So I'd really like to, like I said, continue the conversation and talk about the impact that this would have on the communities we serve.
Well, and so I guess to that, I guess, what would you say to Iowans, just to members of the general public who, as they've been, listening or watching to the news, reading articles about the changes coming up to Medicaid, who, because, maybe they're not on Medicaid, maybe their family members are not on Medicaid, and might have it in their heads that, oh, this doesn't affect me, this doesn't affect my family, this only pertains, to the Medicaid population, to those on Medicaid. I guess how would you explain to them, why this is, I guess, a more global issue?
Yeah, I think what I would say to them is even though you and your family are not impacted by Medicaid, the place where you go get your health care is at 2 a.m. if you need help. The hospital will be impacted by those cuts. And if the hospital will be impacted, then you potentially could be impacted as a direct result of that.
Shelley, when we spoke in our pre-panel discussion, you talked about the importance of balancing independence with collaboration. I guess, what role do partnerships, and we've talked a little bit about telehealth, but I'm kind of curious, what role do partnerships or regional models play, I guess, in terms of like a long-term strategy in addressing some of these issues that we've addressed?
Yeah. So yeah, independence is really important to us because it allows us to focus on our community, like solely on our community. So that's why that's really important to us. But partnering and collaborating is really important because it allows us to enhance the services that we provide within our community with bigger tertiary places. Like they can bring additional services in. Regional models would be great if hospitals can work together rather than compete with each other to provide additional services to communities.
Bill, I'm curious, I guess, how do you see community health centers evolving under this new Medicaid reality?
Sorry, I was muted there. So, I mean, there's honestly across the United States community health centers that are getting closed. I mean, they can't stay in business. I mean, there's community health centers across the state that have less than 60 days of cash on hand to provide care. So I mean, we're in a decent position right now, but in 2 years that could be totally different. So with these changes coming, so it's truly potentially seeing community health centers across the United States close. They've already closed in Chicago and throughout different states. So I think we're going to see more of that, unfortunately, and then that safety net provider will be gone. And then people will use hospitals, unfortunately, as a safety net provider, and hospital ERs aren't meant for primary care. As Chris said, people will get sicker and sicker. Diabetes will get out of control. and then people will need dialysis, and then, you know, they're gonna cost the system actually more money. If we can do primary care well and keep people, keep their diabetes under control, then they don't need dialysis, they don't need, you know, amputations. So that's what we need to do, is make primary care the primary responsibility and the driver of healthcare and lowering the cost.
Yeah, if you don't mind, can you talk just a little bit, I guess, about the populations that you serve through your health centers?
Yeah, so we serve anyone, any patient that walks in our door. Um, and that could be someone with commercial insurance, someone with Medicare, someone with Medicaid, someone without insurance. So we do, as part of our, you know, federal grant, we do get, are required to provide a sliding fee scale for our patients. So people, you know, when they learn that, you know, or don't have insurance for whatever reason, they turn to community health centers because it is a set fee. I know hospitals have different care programs, you know, that can reduce the cost of care. But, you know, it's pretty set. If you call us and you say, this is my income, and this is how much I make, or that your income, and that you have no insurance, we'll tell you, yes, you can come in for a primary care visit for $30. And if you need your medication, you know, we can provide it at a reduced rate because of 340B or the 340B program. So we can really tell people, you know, this is how much it's going to cost for your care. You know, the struggle we have with that is, you know, when someone comes in and they do need services like x-rays, we have agreements with hospitals, but there's not enough specialists and avenues for those people that need that specialty care. So we can really provide that primary care, but, you know, we don't focus on specialty care. So
Yeah. For those unfamiliar, I guess just briefly, what is the 340B program?
I don't know, Chris, do you want to define it, or do you want me to? It's a program that allows us to, right now, buy prescriptions at a reduced rate from the manufacturers. And the great thing about the 340B program is it's not tax funded at all. So it's all taken, you know, a little of the profits from the drug companies and allowing us to use those drugs to lower the cost of care or provide services. But that is also, you know, there's 10 drugs that are moving to a rebate model. So if, for instance, Jardiance, you know, Jardiance may be a $300 drug on the wholesale market, but we can get that for like 30 cents through the 340B program. And then we can provide that Jardiance to a patient for, you know, 30 cents plus a small dispensing fee, you know, for our patients. So, you know, then they can get that drug. Well, Jardiance is one that's going to move to a rebate model. So we have to pay the full cost of Jardiance, and then we'll be able to, once we've used that full bottle, turn that in for a rebate. But then we have to actually cover the cost of that drug until we've used that full bottle. So that's kind of the gist of the 340B. And I know hospitals, they can, Chris or Shelley could talk more about it, but use it for like chemotherapy drugs and, you know, infusions. So it really helps lower the cost of those drugs. So I don't know if Shelley or Chris wanted to talk more about it.
I think I think the thing about 340B is, you know, it helps patients be able to afford the medication, but it saves the hospital or the community health center on the cost of that drug, so that the money that they before we're using to pay to buy the drugs, they can focus on maybe hiring another doctor so they can see more patients. And, so it's kind of a reallocation of the expense to help provide services to the community. The 340B program is a really beneficial program, and it's under a lot of scrutiny right now. So I do hope that legislators really look into that and pay attention to that and understand the impact if that does, if there's any changes to that program as well.
All right. One question that I have, we've been talking about all of the changes involved under the reconciliation bill, the quote unquote one big beautiful bill. The arguments that we've been hearing from Republicans in support of these changes, in support of the legislation, is that Medicaid in its current form is unsustainable, that the current trajectory of Medicaid and Medicaid funding is not sustainable, and changes need to be made to constrain cost. And their argument and their estimation, they say that they believe that these changes, including the work requirements, will strengthen Medicaid and make it better for the core individual or population of people that it was meant to serve and to address. And so I guess how do you respond, I guess, to those arguments or statements from Republicans? And I'll just throw this out to the group.
Yeah, I guess I'll bite the bullet on this one and jump in here. I think really from my perspective, over the past, how many minutes we've been here, for roughly 52 minutes or something. Forgive me if my math is wrong. You've heard from a hospital leader, you've heard from a community health leader that these cuts to Medicaid would be damaging to them. So what good is a strong Medicaid program if the recipients of Medicaid have nowhere to go to get the care that they need, or can't get the care that they need in a timely fashion? So I guess I would agree to disagree on that. If the places where folks need to get healthcare delivered are negatively impacted, then to me, the Medicaid population is negatively impacted, as well as the rest of the communities who aren't on Medicaid, because those cuts impact all Iowans.
Well, we have just a few minutes left. And I kind of want to, I guess one question I have for the group is, I guess, what's the one message you most want Iowans to take away about Medicaid changes and their impact on hospitals and communities? And I guess, Kelly, Shelley, I'll start with you.
Sure. So to Chris's point too, so I think we can all acknowledge that where there is waste or abuse in any government system, we should work to reduce that, right? I think we would all agree on that. But I think the most important thing to understand about these changes to Medicaid is that they don't just alter the policy, they affect real people and the health of entire communities. So hospitals, especially in rural Iowa, are really the backbone of their town. And when Medicaid coverage is reduced or reimbursement falls short, hospitals face really serious challenges in keeping their services open, retaining staff, and staying financially stable. That means families and small businesses may lose timely access to timely health care. So when Medicaid is weakened, not only vulnerable patients suffer, but the entire community potentially loses access to care and economic stability.
Bill, I'll throw the question to you. One message you most want Iowans to take away about Medicaid changes and impact on hospitals and communities?
So, they the speaking points are that, we're just cutting waste, fraud, and abuse from the system. And by putting work requirements in, anyone that follows those plans shouldn't lose coverage. Well, we can't get $1 trillion in cuts without someone falling off Medicaid or, a mass change to system. So, I think we just need to slow down and figure out ways to make changes, because, I agree we need to take the waste, fraud, and abuse out of the system. I'm not against work requirements, I mean, to work 80 hours, a month, I don't think that's unreasonable, but a lot of the people on the system don't have the technology to send that application in, or, they just don't know how. So I think, our Congress is counting on that, like that people are going to fall off, and then it is going to hurt us. And, when you live in a small community, you're going to have to drive 45 minutes to get care. In one of the communities, Keokuk, Iowa, to deliver a baby is 45 minutes to the closest hospital. So, you could have an ambulance that has to come pick you up because you can't get to that hospital in 45 minutes. And so, we just need to think about and slow down the changes. Like I said, I'm not against making changes. It's just we need a structured approach, because everyone knows the government can't continue spending the amount of money without massively raising taxes, which I don't think anyone's in favor of. So we have to make these changes, but we just have to be very careful how we make them.
Yeah. Chris, I don't know if there's anything you want to add on what you've already said. Again, one message you want Iowans to take away. I'm sorry, you're muted.
I almost made it all the way through without messing that up until then. But anyway, I would just echo some of the points of my colleagues here on the panel. I think, from my perspective, one, I don't think there's anybody who is supportive of waste, fraud, and abuse continuing in anything. So I think we're all on the same page about that. But my message to folks would be, if you want to continue to enjoy the service and the access to healthcare that you have in your community, you need to speak to your elected officials about the importance of the hospital, and to remind them to be very careful as they move forward with any potential major policy changes or major cuts, to ensure that it does not negatively impact the delivery of patient care.
All right. We've got about 2 minutes left. I guess just really quickly, jumping off of what Chris said, I'll throw this question to Shelley and Bill just quickly. What is one thing Iowans can do if they are, concerned about the future of Medicaid and the future of rural healthcare? How can they do something to change this or get involved?
I think Chris hit the nail on the head. Talk to your legislators, advocate on behalf of your hospital or your clinic. Learn, right? Like, understand really what the impact of this is, and then just advocate on our behalf.
Bill, anything to add there?
No, I would second that we have to talk to both the state and local Congress and senators. We have to really understand and don't learn about healthcare from social media. Actually, get real information, because there's a lot of misinformation out there about how healthcare works in this country. So, ask trusted people for, appropriate answers.
Yeah. Well, great. Well, I want to thank our panelists, Chris Mitchell, Shelley Cleverly and Bill Grimm for their insights and participating in this. Thank you to our audience for your interest, and thank you again to our sponsors, ITC Midwest and Myron Construction. Up next at 1 o'clock, our closing keynote will feature someone who has helped shape Iowa's food and beverage scene into what it is today, with nearly 4 decades of hospitality experience. Doug Goach, and I apologize if I'm mispronouncing, not only co-founded Big Grove Brewery, but also built partnerships behind some of Iowa's most celebrated restaurants. So that's coming up at 1 o'clock. Encourage you to check that out. Again, thank you everyone for being here, for participating. Really appreciate the discussion. I'm Tom Barton. Thanks for attending.